Okay, I'm gonna get started. So thank you all for joining us today for the Colorado All-Payer Claims Database Research Showcase. My name is Claire Leather, and I'm the Public Reporting Program Manager here at the Center for Improving Value in Healthcare. And I'm gonna get our presentation started today. So, first things first is our agenda. We will kick off with a very brief overview about the Center for Improving Value in Healthcare and the Colorado APCD. I'm going to then briefly discuss some exciting public reports before I hand off the presentation to my colleague Kimi Landry and our community partner David Wright from the Denver Indian Center to discuss their exciting research project that is aimed at understanding health disparities among American Indian and Alaska Native communities in Colorado. They're going to give you a brief introduction to the Denver Indian Center, and they're going to talk about how the problem they're addressing, the outcomes and insights, and some additional resources. And then we'll finish it up with ways that you all can partner with us. Some housekeeping. All lines are muted. Please ask your questions in the chat box. There'll be a Q&A after the presentation. This webinar is being recorded, and we will post the recording on our events resource page shortly after the event is concluded. So who are we? For those who don't know us, we are the Center for Improving Value in Healthcare, or CIVHC for short. We were formed out of a blue ribbon recommendation, and our mission is to equip partners and communities in Colorado and across the nation with the resources, services, and unbiased data they need to improve health and healthcare. Our vision is that everyone has the opportunity to be healthy and have access to equitable, affordable, high-quality healthcare. We are a nonprofit, we are independent, and we are service-oriented. Who we serve. So we serve a number of different audiences and partners in the healthcare space, with the consumers being at the center of our work. We call these partners change agents. These are the folks that are in the trenches seeking to improve healthcare, lower costs throughout Colorado, and they touch on nearly every aspect in the healthcare ecosystem. So these can be clinicians, government agencies, consumer advocates, researchers, employers, nonprofits, the list goes on and on. So we serve in a number of different ways. Primarily, we are the administrators of the all payer claims database for the state of Colorado. And we provide data two ways. We provide public data and non-public data. Today, I will briefly be talking about some public data. The public data we provide helps identify opportunities in the community, ways to improve healthcare. This data is provided via interactive reports, publications, Excel files, infographics. And then there's non-public data that's released to those change agents I just spoke about that license our data for specific project needs. In addition to that, we have a plethora of other services we provide. We provide analytic research and evaluation services. We will be talking about one such project that is an outcome of those services. And then we have a programmatic focus area in advanced care planning and palliative care. And we also have a community engagement program. So if you have any healthcare data needs, please come and meet with us. This is just a brief overview of what is in the Colorado APCD. So this is the data that we're going to be talking about today. It looks like 1.3 billion claims through 2024. That represents about 33 commercial payers, including Medicaid, Medicare Advantage, and Medicare fee-for-service. Our data goes back to 2013, so there's a ton of trend information. And this looks like 70% of the covered lives in the state in 2023, 5.7 million lives in the state for 2023 as well. So what's not included in the APCD is really important. We do not include federal programs like the VA, TRICARE, Indian Health Services, a majority of ERISA-based self-insured programs, and then the uninsured or self-paid claims. So as I mentioned earlier, our presenters are Kimi Landry from Civic. She is an evaluation and research analyst, and then David Wright, the grants manager and public and relations guidance specialist from the Denver Indian Center. He is also here with us today, and they will be talking more later. Before I hand it off to them, I just wanted to touch briefly on two exciting public report releases. The community dashboard, our population health report, is live and has been updated with some new measures and new features in the interactive dashboard that I'm going to share today. And then we have a brand new analysis looking at chronic conditions, 30 chronic conditions in the state of Colorado that looks at utilization and cost. So we're excited to share that as well. And that will be live today. So you'll be able to go and look at that data by the end of the day. So let me just start with the community dashboard. The background for the community dashboard, it was created based on the enabling legislation for the Colorado APCD. So the legislation that created the APCD, it requires the creation and release, of population health information. We do this report annually, and the purpose of the community dashboard is designed to provide insights into healthcare trends, costs, and utilization patterns across the state. The dashboard aims to help communities, policymakers, healthcare providers, researchers identify disparities and opportunities for improvement in healthcare for the state. And I am going to briefly demo this beautiful tool. So let me share my screen. It's going to take me a half a second. I hope everybody can see my screen. Yes. Great. So the best way to get to our data is going to our website, civic.org. Go to Get Data, Public Data, and then Featured Focus Areas, and then the Community Dashboard. Here we have a brief introduction about the Community Dashboard. We have the considerations, and then we have all these lovely use cases. You can see a very a wide group of people can use our data for the work that they do. And then down here is the actual dashboard. The dashboard contains 4 tabs. The first one is sort of overview and definitions to give you a lay of the land. The second one is a county profile kind of snapshot. And here folks can see what's happening by county and compare the data by statewide, urban, and rural benchmarks. They have a lot of selections. The first selection is the measure group to look at. So we have both cost and utilization measures. You also can select DOI region or county. So that's Division of Insurance. So it's the regions that DOI uses to regulate the insurance market in the state. And then you select the geography. So it defaults to Adams County. And you can also select the year. The data goes back all the way to 2013. And then you can select what payers you want to focus on. And then you have a line for every single measure, and you can see sort of what's happening comparatively to the state. So very nice layout to get a deeper dive into a specific geographic region. The Trends tab, which is my favorite and has a lot of new bells and whistles, shows what's happening across the state. And you can also compare and see what's sort of happening to specific counties. So again, you can toggle between cost or utilization measures. You can select a measure. So if you wanted to just look at pharmacy spending, you can do that. And then here you can select multiple counties to compare to on the graph. So we have the statewide, urban, and rural benchmark selected, but you can select additional counties and up to 5, and you can see sort of what's happening. And then you have to apply, which is a new thing that I need to keep remembering to do. Apply your filters. And then you can kind of see what's happening, and you for the trend data, you can also select your payer type, and then down here is the map, and the map kind of gives you a nice overlay of sort of what's happening across the state for any given year, for any given measure. And then last but not least is our ranking. This is a brand new tab. We're really excited about it because we get this question a lot. And folks here can actually see how counties rank amongst each other, compare what's happening. And again, you can look at specific measures, you can look at it by specific geography type, you can look at it by specific payers, and then you can see sort of what the highest utilizers are, where the highest costs are in the state. So we're very excited about it and very excited for all of you to use it and play around with it. So I will stop sharing my screen so we can jump back into the slideshow. Wonderful. So now I'm going to talk about our brand new chronic conditions report. So this report came about because chronic conditions are among the leading cause of death and disability in the United States. They reduce the quality of life, drive up healthcare costs, and place a really heavy burden on the health systems nationwide. So the purpose of our report is to look at sheds light on 30 prevalent chronic conditions in the state from 2017 to 2023 in the claims data from the Colorado APCD. This analysis includes trends in how common these conditions are, the average annual cost, total spending for individuals living with at least one chronic condition as well. This data is provided at the rural, urban, and statewide level, along with the county and DOI level. And we also have demographic information in the report that looks at age and sex. This report will also be available in the same area, and there's a little typo that shouldn't say the community dashboard, that should say the chronic conditions report, but you go through the same path to find it. And it includes 30 chronic conditions. These are based off of CMS. They come from CMS's methodology, and we utilize their algorithm to determine the cost and utilization. There's also 2 additional data sheets that looks at individuals with 1 or more chronic conditions and looks at individuals with 2 or more chronic conditions. So you can kind of see what's happening with those folks because we know that there's a lot of comorbidity among these diseases. So use cases for this report. We hope researchers use this to study trends and conditions, prevalence and spending. They can compare outcomes over time and sort of assess the impact on different health interventions. We hope our friends that are policymakers and folks that work at state agencies can use the statewide data to inform chronic condition disease policy, guide funding decisions, and evaluate health program effectiveness. For employers, they can use the condition and cost data to design benefits that address employee health needs, reducing avoidable spending and support sort of targeted wellness programs. And then our public health entities, we hope that they can identify where chronic diseases are most common and support prevention strategies and prioritize areas for different community outreach. So really excited about this report. It will be live by the end of the day, and you will be able to download all 30-ish data sheets. So yeah, very excited about that. And now I'm going to pass the baton to Kimi and David to take it away.
Thanks, Claire. First, can everybody hear me? I think. Okay, cool. All right. So again, my name is Kimi Landry, and I am a research and evaluation analyst here at Civic. And I'm really, really honored to be presenting with David Wright. He's a grants manager at the Denver Indian Center, and he's been my lovely partner throughout this project. Together, we're both really excited to share results from this 10-year analysis of healthcare claims data, really focused on the American Indian, Alaska Native communities in Colorado. Okay, so I'm going to pass this slide off to David, and he's going to give us a nice introduction on how this project got started.
Thank you, Kimi. Everybody hear me okay?
Yes.
Okay. Thank you, Kimi. So this project actually is about a 3 to 4 year project that we started. The initial idea came out of the Colorado Health symposium, Colorado Health Foundation symposium in Keystone, where we met a number of healthcare partners, particularly first with National Jewish, and then it kind of has moved into a more robust conversation and outcomes-based research. We presented the initial concept and idea of creating a culturally relevant and culturally comprehensive training program for all healthcare providers within the state of Colorado to address the American Indian Alaska Native health disparities as well as social determinants of health concept. We met Amanda Kim right after this presentation, I would say 2 years ago, and then we didn't really get a chance to talk very much because of COVID and all those kind of fun little things that happened. But then we were reintroduced by somebody over at the CDPHE, Colorado Public Health Office. She's a tribal liaison, Kimberly Blackhorse, to CIVHC again, and this project kind of grew from there. And we were able to kind of dive into this data, to be able to grow more understanding and to inform policymakers and education. That's to say that's one of our core areas here at the Denver Indian Center. You can see our mission is to empower American Indian youth, elders, families, and community by promoting self-determination, economic, mental, and physical health through education, advocacy, and cultural enrichment. So particularly this area is the advocacy and education. We definitely also support the emotional, mental, physical, and spiritual health of our families. We have a number of programs here at the Denver Indian Center, everything from our Native Workforce Program, where you are, if they're tribally enrolled, we help them with employment services, job readiness, as well as vocational training, those types of things. The next program that we really focus on is our Honoring Fatherhood program. And so that's working to address the epidemic of fatherlessness within American Indian and Alaska Native people. And that's one of the social determinants of health areas that Kimi will go over as well later on, is the family dynamic areas, particularly intimate partner violence, but also the breakdown of the family unit. And so those are kind of the two main areas. We also serve elders. We're in the process of kickstarting our youth program again. Overall, we have a budget of about 2.6 million for all of our programmatic dollars and stuff like that. But really, it boils down to we have a very limited budget for where we're able to work from. And so it's been great to work in collaboration with CIVHC through their expertise and the collaboration that they were able to provide. So I hope that kind of answers some of the questions on how the partnership was formed. And I'll turn it back over to Kimi.
Thanks, David. That was really great. We'll go to the next slide, Spencer. Okay, so to support these goals that David really spoke on, our analysis focused on 10 years worth of data in the Colorado APCD. So Claire gave us a nice background on really what's in the CO APCD. So I'm just going to go further into our analysis. But we combined demographic and social data with the American Community Survey, which is collected by the census. And this was really because race and ethnicity reporting, after doing some analysis, we found that before 2017, some of the race and ethnic reporting wasn't as strong as we found it to be between 2018 and 2024. So we decided to do a split analysis to reflect those sort of changes. We also used a hierarchical classification method to identify American Indian Alaska Native individuals. So meaning if someone reported more than one race, they were still counted as American Indian Alaska Native. Okay, so we approach this evaluation by asking a few core questions. We first wanted to know what health conditions are most frequently treated or diagnosed among American Indian Alaska Native individuals, especially compared to non-Hispanic white populations. Next, we looked at how care patterns differ, and then of course we examined the cost of that care. And then finally, we explored what the data said about social risk factors. So these, again, will show up in medical claims through something called ICD-10 codes, and then as well as the ACS data. Okay, so now that I've sort of introduced what we asked and the driving eval questions, I'm going to just dig into a little further about how we measured those questions. So I'm going to begin with the diagnosis. We looked specifically at principal diagnosis that's listed on a medical claim. This is the condition that really triggered the visiting event. So it's not like a background diagnosis that a clinician could have put in. This is the triggered event that drove the care episode. We pulled the top 5 principal diagnoses for each racial group and examined how they varied by year. This helped us see which groups are more likely to receive care for certain issues, specifically like chronic diseases, injury, maybe acute mental health concerns. And by looking at these patterns, we could start to get a sense of whether different communities are getting timely and preventative care or more often arriving when issues could already be severe. Okay, next, utilization, cost, and the location of care. So we measured emergency department visits as well as hospital inpatient stays. Then we examined readmissions and follow-up care. These can tell us something about the care quality and are people getting connected to the right services after a major event. The costs were tracked over time, looking at both costs per member and per member per month trends. We compared these across racial groups as well. And then to capture the full financial impact on these individuals and communities, we included out-of-pocket spending. This is because even when total costs look similar, the burden on patients can vary dramatically. And then finally, we mapped where care was delivered. So we identified the top 5 facilities used by American Indian Alaska Native members and watched for shifts in location as more people enrolled or disenrolled in Medicaid and Medicare. Just quickly, I'm going to explain what our cost terms mean because they can be a little confusing as I go through this. So total cost essentially means what the full healthcare system paid. So this includes everything from insurance payments to what people pay out of pocket, okay? And then out-of-pocket costs are what individuals pay directly. These are things like co-pays, deductibles, and coinsurance. And then PMPM just means per member per month. It's a way to average costs so we can compare across groups. For this analysis, though, I want to point out that we did focus a lot on out-of-pocket costs because this can tell us the exact, sort of more of the exact financial burden that people feel, kind of what I mentioned before. Okay, and then the last piece we measured was social risk. So we did that with the ICD-10 Z codes, excuse me. Z codes are a set of diagnosis codes that flag non-medical issues affecting health. So like what David said, these things can be like housing, family stress, economic hardship, work and employment. They are how these Z codes are how we track social determinants of health in administrative data. So it's important to remember not every provider uses Z codes and they're not always used consistently. But when we did see them, they can offer a really important window into different life circumstances that are affecting people. So to add context to the Z codes, We layered in data from the American Community Survey that helped us understand how documented risk aligned with patterns of social vulnerability in different communities. Okay, I'm just gonna go ahead and jump into our cohort. So we pulled all Coloradans with any commercial, Medicaid, Medicare fee-for-service, or Medicare Advantage coverage. This analysis did not include dual eligible people, and that is people that are considered eligible for both Medicare and Medicaid. The final population, or the total cohort size, was 5.6 million unique individuals across a 10-year period. We focused on three key groups. These are the American Indian and Alaska Native individuals. We analyzed whether they were single race or multiracial. For this analysis, you'll see mostly that we combined both multiracial and single race American Indian individuals. Some slides have them separated, but because multiracial was so much smaller of a cohort size, we decided to put them all together. And then non-Hispanic white individuals and people with unknown missing race data. We excluded all racial and ethnic groups like Black, Asian, Pacific Islander, and most Hispanic and Latino individuals, unless they were also categorized as American Indian, Alaskan Native, so we could center those comparisons without introducing too much broad race variability. Okay, next slide. Okay, so just to go over the eligible individuals by race and ethnicity to give you a good idea of what our cohort broke down look like. From 2017 or 2014 to 2017, data on race and ethnicity, as you can see, was a little bit more consistent. So for example, in 2014, about 39% of members were listed as unknown, and American Indian Alaska Native individuals made up roughly 1.5% of the data set. In contrast, 2018 to 2024, we can see that race reporting improved. The share of unknown race members dropped to about 34 to 39%, and American Indian Alaska Native identification stabilized to about 0.7 or 0.8% of the data set. These later years were also definitely more complete in demographic information, and we definitely want to rely on the later years for the deeper analysis. And this is one of those slides I was mentioning about breaking down between single race, American Indian, Alaska Native, and multiracial. So this is really where you can see how small the multiracial American Indian, Alaska Native population really is in Colorado. As you can see, the biggest thing that stands out for me, though, is the steady growth of people that are identifying as multiracial American Indian, Alaska Native. That group nearly doubled over time from 1,100 in 2014 to over 2,000 in 2023. So just something to point out and keep an eye on, that I think there's more identification happening in this group than we originally thought. A breakdown of age and gender, we saw that American Indian Alaska Native members were the youngest, with 60% of that cohort being under age 36. And by comparison, 52% of non-Hispanic white and 47% of unknown race members were 36 and older. Women are the majority across all groups as well, especially among American Indian Alaska Native members. They had the biggest discrepancy. I believe there were 54% female and 45% male in that group. And we also saw a drop in unknown or other gender, which may reflect changes in how gender is being reported. Okay, and then last, I'll go over some eligibility patterns before we jump into the measures. So in claims, we saw that Medicaid was the most common coverage for American Indian Alaska Native members. It has dropped from 76% to 69% though, and commercial coverage has risen from 12% to 18% in that group. Medicare Advantage has also ticked up while traditional Medicare has declined. For multiracial American Indian Alaska Native members, commercial coverage jumped from 57% to 68%, with Medicaid falling to just 15%. And commercial may remain the highest for non-Hispanic white. One disconnect I did want to point out when we did our ACS analysis, the ACS data showed that nearly 60% of American Indian Alaska Native Coloradans reported having private insurance. Yet we can only see a fraction of these commercial claims in the CO APCD. This gap could suggest bigger things, but possibly unused care, maybe possibly out of network or supplemental. Okay. I'm sorry, y'all. I'm going to try to get through the slides and then I will jump and look at these questions if that is okay with y'all. I just have so much to get through. Okay. So now we're going to look at the really focused questions that we're here for. Let's take a look first at what's actually being treated, or the top diagnoses that are being treated. This chart shows the most common diagnosed categories for each group from 2018 to 2024. So what you're looking at are the number of people out of 1,000. So that number at the end of each column is the number out of 1,000 who are treated for each condition. For white and unknown race groups, general checkups and preventative visits are by far the most common. Over 100 out of every 1,000 member. For American Indian Alaska Native members, that number is less than half. To me, that's a very big deal because, as we know, checkups are how most people get screened for care, where you catch a lot of health issues, where you get your preventative care. So seeing that those rates are so low, it can mean that that population is not getting in the door enough and they aren't being offered important preventative services. And you'll also notice that American Indian Alaska Native members show lower rates for mental health, developmental issues, and respiratory conditions. And then you'll see that heart disease doesn't even show up here for American Indian Alaska Native people, even though we know it's a big risk in this population. This likely means that it's not being diagnosed, not that it's not, this likely means that it's not being diagnosed, not that it's not happening. So on one hand, you'll see higher rates for things like kidney and hormone-related conditions. We know these things can be tied to conditions like diabetes, which we also know is more common in the American Indian Alaskan community. So what this chart is really showing us is not just who's sick, it's about who's being seen and who's being treated. When you don't show up in the diagnosis data, that doesn't mean everything's fine. It can mean you're not getting the care that you need. Okay, now let's walk through how healthcare was actually used, starting with hospital stays. So about 25% of American Indian Alaska Native members had an inpatient stay in 2014. By 2013, that did drop to just 10%. That's a huge shift. This could reflect better outpatient management, or it could mean other sinister things like avoiding needed care due to access and coverage. For non-Hispanic white people, we saw the drop was smaller, from 11% to 8.5%. Emergency room visits followed a similar trend. In 2014, 47% of American Indian Alaska Native members visited the ER, compared to 34% of non-Hispanic white members. We did see declines over time for both groups, but American Indian Alaska Native members continue to use the ER more frequently. And then when we look at post-discharge follow-up, those follow-up rates remain low for everyone. Just 5% of people got a visit within 7 days of a hospital stay. So that is pretty concerning, considering complications can happen pretty quickly after hospital stays. And then we also look at readmissions. So American Indian Alaska Native members had the highest rates in earlier years, peaking around 11% in 2019, and non-Hispanic white members peaked later at about 11% in 2023. So overall, while utilization has dropped, these patterns raise concerns about access, delayed care, and possible missed opportunities for better recovery. It's not just about how often people use care, but what happens next. Okay, this slide's going to be a little overwhelming, so bear with me a little bit. This is to give us sort of a big picture of what's going on with utilization trends. You'll see here that the green represents American Indian Alaska Native members, orange is non-Hispanic white, and the light blue is unknown. So you can see all four, so there's 4 different charts here. The top is inpatient admissions. The second is ER visits. Then we have 30-day readmission rates, and then we have 7-day follow-up. Excuse me. So just to sort of follow the trend lines, you can see the green is the highest at the beginning of these years for every single category. Things have since leveled out a bit more, but for the most part, American Indian Alaska Native members have stayed the highest rates in comparison to unknown and non-Hispanic white for utilization. Okay. All right, now we're going to shift to how care, how much care costs, excuse me. So I'm going to start with the big picture first and how costs varied by race, and then I'll do a further breakdown of how costs varied by race for each type of insurance. So let's start with, again, the race category. So American Indian Alaska Native members averaged nearly $1,000 per member per month. That's a pretty consistently high burden. And they also because they used emergency department visits more, and from what we can tell from the data, have fewer specialty visits, this likely can signal gaps in access to preventative or coordinated care, which could increase costs. Then we have non-Hispanic white members. They had a lower total healthcare costs overall, but their out-of-pocket costs were higher, especially under commercial plans. And the unknown race category stood out pretty big. They had the highest total and out-of-pocket costs. This group may reflect people who were misclassified or not identified in the data, but their high burden mirrors a broader issue of visibility in healthcare. Okay, let's look at how these cost patterns are playing out under Medicaid, which is the most common type of coverage for American Indian Alaska Native members in this data set. So Medicaid spending for American Indian Alaska Native members peaked early. In 2014, their average total cost was over $1,600 per person per month, with claims averaging around $350 each. Out-of-pocket costs were higher too, about $75 a month before dropping sharply in 2020. Then we have non-Hispanic white members that followed a similar trend, but with slightly lower total costs. By 2020, their out-of-pocket payments dropped to less than 25 cents per month. This was actually very similar to the American Indian Alaska Native members as well. And then the unknown or missing race group had slightly different pattern. Their overall costs dropped quite a bit after 2018, and the out-of-pocket costs were, the overall costs dropped quite a bit after 2018, and the out-of-pocket costs were already pretty low to begin with. What we saw from across the board by 2020, out-of-pocket costs were very low for everyone. And I honestly think this highlights Medicaid's role in helping people with financial burden. All right, now we have commercial care. So among members with commercial insurance, American Indian Alaska Native individuals consistently paid less per month, about $72, both in 2014 and again in 2023. In comparison, non-Hispanic white members paid more than twice as much in 2014, about $160 per month. and they continue to pay more over time. They're averaging around $96 in 2023. And the unknown group, once again, had the highest cost, peaking at $194 per month. And then last, under Medicare, American Indian Alaska Native members started with the lower monthly costs from 2014 to 2017. But by 2018, cost gaps did start to widen, especially as more members enrolled in Medicare Advantage plans, which often shift more costs to the patient. We saw that non-Hispanic white members averaged over $180 per month, and those with Medicare Advantage tended to have higher overall cost burdens. And the most expensive group, once again, was the unknown category. In 2023, their costs reached $109 per month under Medicare Advantage. So across all payer types, we can see it's pretty clear that there are strong racial disparities. I think that reflects deeper patterns that we're not seeing. So with American Indian Alaska Native communities, they're facing early high costs and care disruptions, while others absorb higher long-term financial burdens. Okay, I'm going to dig into a little bit of the utilization and analysis by city and hospital. So let's see what's going on with care among the states. We saw that in the more recent years, Denver Health remains the top hospital for American Indian Alaska Native members, with nearly 60,000 visits between 2018 and 2024. Next was the University of Colorado Medicine facilities in Aurora, which was about 40,000 visits across 2 different Aurora campuses by American Indian Alaska Native members. The biggest thing that really stood out among this data was the Kaiser affiliated facilities and the visits that are rising there. So back in 2014 to 2017, only about 5% of American Indian Alaska Native members received care at Kaiser. That's roughly maybe not 9,000 visits. But by 2018 to 2024, that number jumped to over 45,000 visits. This could reflect a key shift in preference, or it could reflect a shift in more toward commercial care. We know Kaiser does offer commercial insurance, so it could be a reflection of more American Indian Alaska Native people moving to commercial care. For non-Hispanic white and unknown race, Kaiser was already the dominant provider. Over 65% of their visits, consistently happening in Kaiser. So while the total number of visits still centers around a few major hospitals, these trends show us something deeper. Insurance coverage could be shifting and shaping where people are going for care. Okay, I'm going to shift to our last question. This is going to be on what social challenges really showed up in claims data through ICD-10 Z codes. So for context, I'm just going to explain a little bit of 2014 to 2017 because Z codes really, there were not a lot of Z codes in claims data before then. So for context, 2014 to 2017, legal issues and homelessness were most common. From what we can tell on the chart in this slide from 2018, spouse and partner conflict was the most documented concern across all race groups. For non-Hispanic white individuals, this accounted for over 230,000 claims. And for American Indian Alaska Native individuals, while this total is much lower, about 2,500 claims, this is still a top social determinant documented. So after that, we see concerns related to upbringing. This includes child abuse, neglect, or separation from parents. And then last, housing instability. American Indian Alaska Native individuals show up in every category here, granted at much lower volumes, but this still means that they are being documented no less. This could reflect we obviously have documentation challenges with Z codes, and I think increasing Z codes would definitely show a lot more, but it's a gap we we take into account. Okay, and then I'm just going to give, to better understand sort of how social risk scores show up in claims, we wanted to compare these claims findings to data from the 2023 American Community Survey, which measures, again, more broad risk exposure. So as mentioned earlier, one of the first gaps we noticed was in insurance coverage. So like I said, 60% of American Indian Alaskan Native members reported having private insurance, but in the CO APCD eligibility files, only 15% of those individuals were captured as commercially insured. And when we looked at public coverage, we saw another reversal. ACS shows that 45% of American Indian Alaskan Native individuals had some form of public coverage, but in the CO APCD, 72% were enrolled in Medicaid and only 7% for Medicare fee-for-service. We also looked at disability prevalence. ACS data shows that 17% of American Indian Alaskan Native individuals report having a disability, compared to 12% of white individuals. This could suggest higher needs for long-term care, mobility support, and chronic condition management needs that aren't being met or may not be well documented. Altogether, this comparison really highlights the limits of relying solely on claims or census data for social determinants of health. Okay, to wrap this up, from what we can tell, this analysis really reveals clear and persistent disparities in healthcare utilization and costs for American Indian Alaskan Native communities in Colorado. Even with coverage, American Indian Alaskan Native individuals still face higher rates of chronic illness, greater reliance on emergency care, and more financial barriers to getting the care they need. While claims data helps us see where those burdens show up, they can't tell us the full story. They must be paired with community expertise and lived experience to create interventions that actually work. One opportunity to support American Indian Alaskan Native health leaders and providers is with tailored cultural training. Ultimately, leveraging real-time data alongside lived experiences gives us the clearest path forward to build systems that not only track disparities, but actually help close them. All right, and then limitations. Before I wrap up, I just really want to acknowledge a few key limitations. So first, the race and ethnicity reporting did change, as I mentioned, over time. That's why we did split the analysis. We noted before 2017, things were different, and then 2018 to 2024. This could mean that American Indian Alaska Native individuals may have been misclassified or left out, especially in those earlier years. Second, the data set for 2024 is still incomplete. We finished this analysis before we had complete data. So yeah, just something to keep in mind. The APCD also doesn't capture every single American Indian Alaskan Native person. It excludes, obviously, what Claire mentioned. We do not have IHS individuals, TRICARE, or ERISA regulated commercial plans. And we also do not have uninsured individuals. And then I've also, I feel like, explained pretty extensively the Z code reporting and the challenges that were related there. And then finally, CIVHC does follow CMS standard data suppression policies. So that means any breakdown with fewer than 11 individuals is hidden, limiting our ability to fully disaggregate the data, especially for American Indian Alaskan Native populations in smaller geographic or demographic groups. Okay, and I've got some references, and then I've got a slide with just some connecting information if anybody would like to reach out to any of us. I am going to now try to jump over to the questions chat. Okay, Jane, I see capture out-of-pocket costs. Right, and I see Claire responded. Yes, yeah. So it comes all through what comes through a claimed bill. So we take that into account with deductibles, coinsurance, premiums, things like that. Those will all come in as sort of an out-of-pocket variable. Can we talk to adolescent coverage, specifically the impact? Unfortunately, we did not do a focused analysis on adolescence per se. I know that is a very interesting topic, and it's something you know, I know Medicaid Unwind is a huge deal right now. We actually had the opportunity to do a different eval project with Youth Healthcare Alliance earlier this year, and did some eval for them on sort of the idea of Medicaid Unwind and how it's affecting school-based health centers. So I I I know your point of view here, but no, we did not do a focused analysis on the adolescent coverage for Medicaid in this population. Sorry, y'all, trying to get through 'em. So if the health policy requires a copay. Yes, Jane, I think you are correct in that. Yes, Claire answered you. Okay. For the ACS versus claims difference in commercial insurance percentage, do you know what that looks like for other racial groups? I do not. We did not do a comparison with other racial groups, but another thing that I want to also put a plug in for, because of this wonderful partnership that we got to have with David, and he spread the word on this report. It sounds, we're hopefully moving forward with a proposal and working with the Center for African American Health, and yeah, and hopefully doing an analysis on the African American and Black population in Colorado. So that's another racial group we might do a whole other focus on, but we didn't do any for this one, unfortunately. Okay, did you by chance look into how American Indian and Alaska Native population? Unfortunately, no, we did not look into anything. We don't have any insight on IHS at all, unfortunately. It's a huge bummer. Do you have, David, did you have addition?
Yeah, so one of the contexts that should be known about IHS is they actually do not track specific data like what we're talking about here. IHS does not have the capability or the process for doing that. It's something that's been in discussion of needing to create mechanisms to be able to measure and track health disparities and issues within the American Indian Alaska Native process. IHS as a whole within the Denver metro area, there is one clinic, and that's it. They have a staff for medical of about, I think, 7 to 8 individuals, with only 2 of those being mental health providers. So as you can tell from those numbers, there is a very limited access to Indian Health Service providership as a whole. And so looking at it from a 50,000-foot view, with the utilization higher in the Denver Health, UC Health, and Kaiser systems, that speaks for us at the Denver Indian Center that there is a need and education process of how do individuals utilize additional care without having that cost burden spread back to them, because there's not a cost agreement coverage for IHS patients with hospital systems. So this is something that is a more complicated kind of conversation. It's also a national policy issue. With under the current landscape, it's going to be a more difficult lift for having those kind of conversations on changing policy and things like that. around IHS, but I think from a state of Colorado standpoint, I think there's a lot more to be done from a policy and analysis standpoint. That's something, just a little bit of, a little more nuance of IHS. This is also, there's a contributing amount of factors that when we talk about social determinants of health, there's historical trends that create those mechanisms. The reservation system, boarding schools, forced removal, as well as forced sterilization processes, forced experimentation, as well as underutilized access because of, for our rural populations, distance from healthcare providers. The lack of internet connectivity for telehealth, those types of things are all contributing issues when we're talking about American Indian social determinants of health, but also health disparities. One of the big things around reservation systems is they were given rations that were very high in carbohydrates and salts, which lead to the higher issues of the endocrine, diabetes, but also cardiovascular issues as a whole. One of the things that was also that I was able to glean from the data, and Kimi, correct me if I'm wrong, is that a lot of the individuals being grouped in illness unknown is a larger concern, because there are, at least in my viewpoint, individuals that are being left out, and or diagnosis that are being grouped into the illness unknown, particularly our cancers and things like that. So I think there's a lot more of creation of more reporting policies, but also education that's needed for individuals to be able to deliver the quality care that is needed. Because we see through anecdotal and through particular, spread across the board, is cancer is one of the higher prevalence diagnosis. But as we're seeing within the civic data for Colorado, it's not being captured either, is that cardiovascular. And so for me, that's a concern of documentation, and also that the non-consistent use of Z codes, I think, is also a concern, and I think an opportunity for development and education, but also creating new policies and education processes for our healthcare providers. And when I talk about, and the center talks about healthcare providers, that's everybody from a receptionist standpoint to specialty doctors and everything else.
Yeah, thanks, David. Yeah, you're right. The unknown categories are a very important gap in recognition. We have unknown categories in those diagnoses, and then look how large our unknown race category is. So, that alone is still a limitation to this data. Yeah. And even the more research we do on commercial insurance, things like that, we find that race and ethnicity data is just not reported on often. It's a huge gap. Darren, I see your last question for your claims-based estimate of disabilities. Did you include dual eligibles? So we did not do a claims-based estimate on the disabilities. That was purely the ACS data. So the information that I gave on, if Spencer, if you could scroll to, I think my social determinants of health, or sorry, the ACS one, I think it's this one right here. So one more. Yes. Cool. So yeah, we did not, this is all just ACS data in terms of what we found for in ACS data, and then what we didn't find in claims data. So we can't measure disability. All I know is the comparison between the American Indian and Alaskan Native folks to white individuals in ACS data. So yeah, that estimate doesn't include claims at all.
Kimi, did we answer Sue's question?
Oh, I'm sorry. Is there one further up? Did you by chance look at, oh, you're getting us using private insurance, the as supplementary means to IHS? Was that the question that you're talking about? Yes, is that the one that we were just speaking about?
Oh, yeah. Now I remember. Sorry.
It's okay. No,
I
but
need
yeah,
some more sleep, I think.
right. Feel like we all do.
Yeah.
Okay. Yeah, are there any other questions anybody would like to ask? I know we're at time, but if anybody has anything else, I'd be happy to stay over or anything like that. Great. Okay. Spencer or Claire, I think unless y'all have anything last to say, I think we're all set. Awesome. Thank you so much, everybody, and I really appreciate your time today. And David, thank you for joining me.
Thank you, Kimmy, for everything. Thank you, Claire. Thank you, Spencer. Thank you to everybody that joined as well. Please
Yes.
reach out if you have any questions.
Please. Thank you.
Thank you.